Arthritis refers to inflammation or degeneration of the joints. There are more than 100 types of arthritis, but the most common type, especially in older adults, is osteoarthritis. Osteoarthritis is a chronic, progressive joint disorder characterized by the breakdown of articular cartilage, leading to pain, stiffness, and decreased mobility. Arthritis itself is a general term meaning joint inflammation. Common symptoms include joint swelling, joint pain, stiffness, and decreased range of motion. Arthritis types include osteo, which is degenerative, rheumatoid arthritis, which is autoimmune, or gout, which is metabolic. Osteoarthritis is caused by the wear and tear on the joints over time. It is non-inflammatory in the early stages and most commonly affects knees, hips, hands, and spine. Age is the most common factor, and it occurs in adults over age 50 because the cartilage becomes thinner and less resilient with age. It happens with repetitive motions such as lifting or bending, or previous joint injuries. Obesity or extra weight increases pressure on weight-bearing joints such as your knees and your hips and predisposes them to arthritic changes. Some individuals inherit a tendency towards cartilage breakdown. This is more common in individuals assigned female at birth, especially after menopause. It is also more commonly found in jobs with repetitive stress or high-impact activities. OA develops gradually. The cartilage deteriorates, becoming rough and thin. Bone-on-bone contact develops. Bone spurs or osteophytes form. Joint space narrows. Inflammation occurs later due to irritation. Pain, stiffness, and decreased mobility result. Primary symptoms are joint pain with movement, stiffness, especially in the morning, typically resolving after 30 minutes, crepitus, decreased range of motion, joint swelling, and tenderness on palpation. Later signs include joint deformity, increased pain, even at rest, and muscle weakness around the surrounding joint. The diagnosis is typically done with a history and physical, X-rays, MRIs, and lab tests. Treatment is focused on pain control, maintaining function, and slowing progression. Non-pharmacological treatments include low-impact exercise such as walking or swimming, weight reduction, assistive devices, heat therapy to release stiffness, and cold therapy to reduce pain and swelling, and often physical therapy to improve strength and mobility. Pharmacological treatments include acetaminophen, NSAIDs, topical agents, or even corticosteroid injections. Surgical treatment is a knee or hip replacement in advanced disease. Considerations: assessing for pain, ability to perform ADLs, gait and bounce, and joint swelling or tenderness. Interventions: administer medications as prescribed, provide heat and cold therapy, encourage weight management, teach joint protection techniques, promote low-impact exercises, and monitor for side effects of medications. Patient education: keep moving through regular exercise, avoid high-impact activities, use assistive devices to reduce pain, maintain a healthy weight, take medications as directed, and report worsening pain or decreased mobility. Rheumatoid arthritis and psoriatic arthritis are autoimmune inflammatory arthritic conditions. The immune system mistakenly attacks joint tissues, causing chronic inflammation, pain, swelling, and progressive joint damage. In rheumatoid arthritis, or RA, the autoimmune system destroys the synovial membrane. This leads to pannus formation, cartilage destruction, and joint deformity. This is typically symmetrical, occurring on both sides of the body. Signs and symptoms are warm, swollen joints, persistent morning stiffness well after an hour, fatigue and malaise, symmetrical involvement of the hands, wrists, feet, joint deformities, and systemic effects such as anemia, nodules, and lung involvement. The diagnosis is done through elevated ESR and CRP, a positive rheumatoid factor, positive anti-CCP antibodies, and X-rays that show joint erosions. Medications for treatment are NSAIDs, corticosteroids, DMARDs with methotrexate being first, and often biologics. Non-drug measures include heat, cold, gentle exercise or range of motion, and resting during flares. Considerations for nursing: monitor for medication side effects, report worsening symptoms, encourage regular follow-up, and support joint protection strategies. Psoriatic arthritis, or PSA, is associated with psoriasis, which is a chronic autoimmune skin condition. Immune-mediated inflammation occurs in joints and skin, can be asymmetrical or symmetrical, and can involve the spine, which is spondylitis. Signs and symptoms are joint pain and swelling, morning stiffness, nail changes such as pitting or ridging, and psoriatic skin plaques. Diagnosis is based on symptoms and a history of psoriasis, imaging showing joint changes, and RF negative, which distinguishes PSA from RA. Treatments are NSAIDs, DMARDs, biologics, topical therapies for psoriasis, and physical therapy. Nursing considerations: monitor for skin lesions, encourage medication adherence, support emotional and psychological needs, educate on disease progression, and promote gentle exercise and joint progressions. Peritonitis is a serious life-threatening inflammation of the peritoneum, the membrane that lines the abdominal cavity and covers the abdominal organs. This is a medical emergency requiring rapid recognition and treatment. Peritonitis can result from infection, chemical irritation, trauma, or perforation of abdominal organs. There is primary spontaneous peritonitis, which occurs without an obvious source, or secondary peritonitis, which is the most common type, resulting from organ rupture or leakage. When the peritoneum is contaminated by bacteria, stomach acid, bile, urine, or intestinal contents cause severe inflammation, fluid shifts into the abdomen and hypovolemia, bacterial toxins spread, causing a systemic infection, and the risk of sepsis and shock increases. Without treatment, this quickly becomes fatal. Signs and symptoms: severe abdominal pain, board-like rigid abdomen, rebound tenderness, guarding, and decreased or absent bowel sounds. Systemic symptoms are fever, chills, tachycardia, tachypnea, nausea and vomiting, and signs of sepsis. Late symptoms are hypotension, confusion, and shock. Diagnosis is made on a physical exam with lab tests showing leukocytosis, an elevated lactate indicating sepsis, and blood cultures. Abdominal x-ray will show free air indicating perforation. A CT scan identifies the sources, and an ultrasound shows fluid and abscesses. Treatment: peritonitis is an emergency requiring rapid intervention. Medical treatment may include IV broad-spectrum antibiotics, fluid resuscitation, electrolyte correction, and pain management. Surgical treatment is often required for perforations, appendicitis, obstruction, ruptured organs, or abscess drainage. As a nurse, you play a key role in early recognition, monitoring, and providing supportive care. Complications are sepsis, septic shock, abscess formation, paralytic ileus, multi-organ failure, and death if left untreated. Lupus, most commonly called systemic lupus erythematosus, or SLE, is a chronic autoimmune disorder in which the immune system mistakenly attacks the body's own tissues, causing widespread inflammation and organ damage. Lupus can affect the skin, joints, kidneys, brain or nervous system, heart and lungs, and blood vessels. It is a lifelong disease with periods of flare-ups and remissions. Lupus develops when the immune system produces autoantibodies that attack its own cells. Potential causes are genetic predisposition, hormonal influences, environmental triggers, and certain medications. Common risk factors: it is more commonly in individuals assigned female at birth, usually diagnosed between ages 15 and 45, a family history of autoimmune disease, sunlight or UV exposure, infection, stress and fatigue, and certain medications. Lupus is often called the great imitator because symptoms can vary widely. Common symptoms are fatigue, joint pain, swelling and stiffness, muscle aches, low-grade fever, and photosensitivity. Skin symptoms include the butterfly rash across cheeks and nose, discoid skin lesions, and hair loss. Systemic symptoms include kidney involvement, pericarditis, pleuritis, headaches, confusion, and seizures, and anemia or decreased platelet counts. Laboratory tests used for diagnosis: the ANA is often positive, the anti-double-stranded DNA, anti-Smith antibodies, CBC, which may reveal anemia, urinalysis reveals proteins, and ESR and CRP is elevated. There is no cure for lupus, but symptoms can be controlled. NSAIDs for joint pain and inflammation, corticosteroids reduce swelling and control flares, antimalarials is the cornerstone therapy, immunosuppressants, and biologics. Non-pharmacological management includes sun protection, stress reduction, balanced diet, resting during flares, and light activity during remission. Lupus can affect major organs, especially during flare-ups. Potential complications are kidney failure, blood clots, stroke, heart attack, chronic pain, and high infection risk due to immunosuppressants. Nursing considerations are assessing for changes in pain, swelling, and skin lesions, assessing for kidney involvement, checking temperature for signs of infection, and monitoring respiratory symptoms. Interventions include administering medications as prescribed, encouraging rest during flares, applying non-pharmacological pain management, promoting skin protection, and reinforcing importance of follow-up appointments. Patient teaching is important in avoiding prolonged sun exposure, taking medications consistently, recognizing early signs of flare-up to be fatigue, rash, and joint pain, stress management and balanced lifestyle, and infection prevention strategies. Human immunodeficiency virus, or HIV, is a retrovirus that attacks the immune system, especially CD4 and T lymphocyte cells. CD4 cells coordinate the immune system response. As they decrease, the body becomes vulnerable to infections and cancers. HIV works by entry. The virus enters the bloodstream through sexual fluids, blood, or perinatal exposure. The HIV then attaches to the CD4 receptors. The virus inserts genetic material. Reverse transcription occurs. Integration of the viral DNA integrates into human DNA, and the new HIV particles produce, released, and infect other cells. AIDS is acquired immunodeficiency syndrome and occurs when the CD4 count is over 200 cells per mm cubed, or the patient develops AIDS-defining illnesses such as PCP pneumonia, Kaposi sarcoma, cytomegalovirus, or wasting syndrome. Risk factors are transmission routes such as sexual contact, blood exposure, perinatal, or occupational exposures. It is not transmitted by casual touching, tears, saliva, or sweat, toilets, food, or utensils. Risk factors include unprotected sex, multiple partners, IV drug use, a mother with uncontrolled HIV, or lack of access to testing and prevention services. Epidemiology notes, HIV remains a significant public health issue. Antiretroviral therapy, or ART, has dramatically improved life expectancies. The physical impact is the progressive immune suppression, increased risk of opportunistic infections, chronic inflammation such as cardiovascular, kidney, and neurological issues may occur. The psychosocial impact is the stigma or discrimination, fear of disclosure, mental health concerns, and barriers to care. In older adults, they may have a delayed diagnosis, multiple comorbidities, polypharmacy use, faster disease progression without treatment, and higher cardiovascular and renal risks. Preventative measures include condom use, pre-exposure prophylaxis, needle exchange programs, routine HIV testing, and treatment as prevention. Clinical presentation or labs and diagnostics, early acute HIV infection, Flu-like symptoms with fever, sore throat, and lymph node swelling are present, rash, fatigues, and headaches. Chronic HIV infections often may be asymptomatic for years, have persistent lymphoadenopathy, and mild infections. AIDS symptoms include weight loss, chronic diarrhea, opportunistic infections, night sweats, oral thrush, and neurological changes. HIV screening is done via the fourth generation antigen antibody testing. Rapid tests are available. Confirmatory testing is the HIV-1 or HIV-2 differentiation assay. Viral load measures the amount of HIV RNA in the blood. The goal with treatment is to have an undetectable viral load. The CD4 count, normal is 500 to 1600 cells. Additional labs might be your CBC and your CMP, liver and kidney function tests, screening for TB, hepatitis B and C, and further STI screening. The nurse's role is to ensure medication adherence. ART must be taken consistently every day, and missing doses can lead to viral resistance. Education for prevention. Lifestyle and healthy maintenance include balanced nutrition, avoiding drugs and alcohol that worsen organ damage, vaccinations, and hand hygiene and infection prevention. Psychosocial support, encourage disclosure to trusted support, refer to counseling, and address stigma and mental health concerns. Treatment therapies are the ART, which is a combination therapy using 3 or more drugs from various classes. The goals are to support viral load, increase CD4 count, reduce complications, and prevent transmissions. Management of opportunistic infections with antibiotics for bacterial infections, antifungals for thrush, and prophylaxis for PCP. Vaccinations such as flu, pneumococcal, hepatitis A and B, and COVID-19. Supportive therapies for nutrition support, counseling and mental health support, physical therapy, and pain management. Kaposi sarcoma is a vascular cancer that forms in the lining of the blood and lymphatic vessels. It's associated with human herpes virus, or HHV8, and occurs most commonly in individuals who are immunocompromised, especially those with HIV or AIDS. It is considered an AIDS-defining illness, meaning that its presence automatically places the client into the category of AIDS, regardless of the CD4 count. It is a malignancy of endothelial cells lining blood vessels. Because HIV weakens the immune system, HHV8 can activate and cause uncontrolled growth of these cells. KS causes purplish, red, or brown lesions, lesions on the skin, mouth, lymph nodes, or internal organs, and vascular tumors that may bleed easily. Primary causes are infection with HHV8. Not everyone with HHV8 develops KS. An immunocompromised state is typically required. Risk factors are untreated or advanced HIV or AIDS, a very low CD4 count, organ transplant recipients on immunosuppressants, older adults from Mediterranean or Eastern European regions, and men from certain African regions where HHV8 is more prevalent. Types of Kaposi sarcoma are HIV-associated, most common in patients with uncontrolled HIV, and strongly linked to immune suppression. Classic KS occurs in older adults and has a slow progression. Endemic African KS occurs in younger individuals in sub-Saharan Africa. Transplant-associated KS occurs in organ transplant recipients due to immunosuppressive medications. Signs and symptoms are the skin lesions that are purple, red, or brown patched nodules or plaques, may appear on legs and feet, face, especially the nose, the hard palate of the mouth, and the genitals. Symptoms of internal involvement include gastrointestinal lesions with bleeding, abdominal pain, or nausea and vomiting, lung involvement with cough, shortness of breath, and hemoptysis, and lymph node involvement with swelling, pain, or edema in the legs. Diagnosis is done via physical exam and confirmatory tests with biopsies. Lab work will be a CD4 count, viral load, and routine HIV labs. Treatment is ART, which is the most important treatment as it restores immune function. It often causes KS lesions to shrink or disappear. Local treatments for smaller limited lesions such as cryotherapy, radiation, surgical removal, or topical chemotherapy can be used. Systemic treatment for widespread disease includes chemotherapy and immunotherapy. Management of symptoms includes pain control, wound or skin care, and treatment of respiratory and GI symptoms. Nursing considerations are assessment of skin and watching for signs of internal involvement, tracking CD4 counts, and observing for side effects of ART or chemotherapy. Interventions encourage strict ART adherence, teaching daily skin inspection, providing wound care, managing pain and comfort, and reporting worsening symptoms or new lesions. Education is important with the importance of adherence of medical follow-ups. Prognosis improves dramatically with effective HIV treatment. Without ART, KS can progress to severe organ involvement. Early diagnosis and therapy lead to better outcomes. Bacterial and viral infections are among the most common causes of illness. Although both are caused by microorganisms, they differ significantly in structure, reproduction, treatment, and clinical presentation. Understanding the differences is essential for nursing assessment, infection control, and patient education. Bacteria are living, single-celled organisms and can survive independently. Many are harmless or even beneficial, but some cause disease. They have a classified shape, staining, and growth pattern. They are typically treated with antibiotics as appropriate. Viruses are non-living infectious particles and require a host cell to reproduce. They are much smaller than bacteria, cause a wide range of illnesses from mild colds to severe systemic diseases. Antibiotics do not work. They are treated with antivirals, vaccines, and supportive care. Bacterial infection mechanisms include rapid multiplication of bacteria. They produce toxins that damage tissues, and they trigger inflammatory responses. Viruses enter the host cell using host machinery to replicate and cause cell death or altered cell function. This then triggers the immune response. Bacterial infections include strep throat, UTI, some forms of pneumonia, MRSA, tuberculosis, gonorrhea, and chlamydia. Viral infections include influenza, COVID-19, HIV, hepatitis A, B, and C, herpes, and RSV. Bacterial infections are localized symptoms. In bacterial infections, localized symptoms are more common, such as redness, swelling, heat, pus, drainage. High fevers may occur, and patients will often have a high neutrophil count. Viral infections, you will see more systemic symptoms, such as fatigue, body aches, fever, nasal congestion, and sore throat. White blood cell count may be normal or show elevated lymphocytes. Diagnosis includes lab tests for culture and sensitivity for bacteria, PCR testing for both viral and bacterial infections, antigen testing, and CBC with differentials. Treatments of bacterial infections include antibiotics. It is important to educate patients to complete the full course. It is only effective for bacterial pathogens, and overuse leads to resistance such as MRSA. Drainage of the abscess may need to occur, and supportive care of fluids and rest. In viral infections, antivirals are used for the specific infection. Vaccines may prevent viral infections such as the flu, COVID-19, hepatitis, and HPV. Supportive care of hydration, antipyretics, rest, and symptom relief are encouraged. Complications of bacterial infections can be sepsis, organ damage, abscess formation, osteomyelitis, and meningitis. Viral infections can include complications such as secondary bacterial infections, chronic illness, severe inflammation, and organ involvement. The infection control differences. Bacterial infections, standard or contact precautions depending on the organism, hand hygiene, and proper antibiotic use to prevent resistance. Viral infections may include respiratory precautions for airborne or droplet viruses, isolation for highly contagious viruses, and vaccination. Influenza is a highly contagious viral respiratory infection caused by influenza viruses. It affects the nose, throat, and lungs and can range from mild illness to life-threatening complications, especially in the vulnerable populations and those with chronic disease. Influenza A is the most common. It causes seasonal epidemic outbreaks. It is capable of antigenic shifts and drift and allows new strains to emerge. Influenza B causes seasonal outbreaks but is generally milder than type A and mutates more slowly. Influenza C causes mild respiratory illness and rarely causes epidemics. Influenza D primarily affects cattle. It is not known to infect humans significantly. Modes of transmission of influenza: droplet transmission such as coughing, sneezing, or talking; contact transmission such as touching contaminated surfaces, then touching your face. Incubation period is 1 to 4 days. Individuals are contagious 1 day before symptoms appear and for up to 5 to 7 days after, longer in children and immunocompromised persons. Signs and symptoms of influenza usually begin abruptly with fever and chills, cough, which is dry and persistent, sore throat, runny or stuffy nose, headache, muscle or body aches, fatigue, weakness, and loss of appetite. Sometimes, in children, they may have vomiting and diarrhea. Certain groups are at high risk for severe illness. Major complications include pneumonia, viral or secondary bacterial, respiratory failure, exacerbation of chronic illnesses such as COPD, asthma, or heart disease, dehydration, sinus and ear infections, and even sepsis. Life-threatening complications such as ARDS and multi-organ failure may occur. Diagnostic tests such as the Rapid Influenza Diagnostic Test, Rapid Molecular Tests, or PCR, which is the gold standard and most accurate. Other assessments may include a pulse oximetry, a chest x-ray, and a CBC to show elevated white blood cell count in bacterial co-infections. Treatment therapies are antiviral medications, which are most effective when started within 48 hours of symptom onset. Supportive care such as rest, increased fluids, antipyretics, cough suppressants, or expectorants as ordered, and humidified air. Hospitalization may be needed if the patient is severely dehydrated, is in respiratory distress, or is in a high-risk population for complications. Annual influenza vaccines are updated each year to match circulating strains and are recommended for individuals 6 months and older. It reduces the severity even if infection occurs and is critical for healthcare workers, older adults, and people with chronic disease. Infection control measures include hand hygiene, respiratory etiquette, avoid contact with sick individuals, cleaning high-touch surfaces, and staying home when sick. Antiviral prophylaxis may be prescribed for high-risk exposures. Sinusitis, also called rhinosinusitis, is the inflammation of the mucosal lining of one or more of your paranasal sinuses. It may be acute, subacute, chronic, or recurrent. It is commonly caused by viral infections and can also be due to bacteria, allergens, or structural issues that obstruct drainage. The parasinuses include your frontal sinuses, maxillary sinuses, ethmoid sinuses, and sphenoid sinuses. The function of the sinuses is to warm and humidify inhaled air, enhance voice resonance, reduce skull weight, and to produce mucus to trap pathogens. When the sinuses become blocked or inflamed, mucus accumulates, leading to infection. Viral is the most common cause. It often follows a cold or upper respiratory infection, and the symptoms appear 7 to 10 days and may indicate bacterial involvement. The bacteria are Streptococcus pneumoniae, Haemophilus influenza, and Maxillariella catarrhalis. Fungal is rare, but occurs mostly in immunocompromised individuals. Non-infectious causes can include allergic rhinitis, nasal polyps, deviated septum, and chronic exposure to smoke or pollutants. Acute types often last greater than 4 weeks, subacute 4 to 12 weeks, chronic under 12 weeks, and recurrent is under 4 episodes per year. Signs and symptoms can include nasal congestion, purulent nasal discharge, often yellow or green, facial pressure or pain worsens when leaning forward, headache, postnasal drip, reduced smell or taste, and dental pain in your upper teeth. Systemic symptoms are fever, fatigue, and malaise. Red flag symptoms are severe headaches, periorbital swelling, high fever, vision changes, and confusion, which these all require immediate medical attention. Diagnosis is done with an H&P and palpation of the sinuses and observation of nasal discharge. Treatment for viral sinusitis is none, only supportive care of rest, hydration, analgesics, saline sprayer irrigation, humidifiers, warm compresses, and short-term use of decongestants. Bacterial sinusitis, antibiotics should be considered if symptoms have been greater than 10 days. Severe symptoms of fever of 102 or higher with purulent discharge, or symptoms worsen after initial improvement. Common antibiotics are amoxicillin, augmentin, and doxycycline. Chronic sinusitis treatment is nasal corticosteroids, allergy management, and surgery if structural issues persist. Complications, uncommon but serious, can be meningitis, abscess formation, osteomyelitis, and chronic sinusitis. Meningitis is an inflammation of the meninges, the protective membranes covering the brain and spinal cord. It is a medical emergency, especially when caused by bacteria, because it can quickly lead to brain damage, hearing loss, seizures, or death. Meningitis can be bacterial, viral, or fungal, with bacterial meningitis being the most severe. The meninges include 3 layers: dura mater, arachnoid mater, and pia mater. The subarachnoid space contains the CSF, which helps cushion the brain and spinal cord. When pathogens invade the CSF, inflammation occurs, increasing intracranial pressure and causing neurological symptoms. Bacterial meningitis, the most severe, is often caused by organisms, meningococcal, pneumococcal, or HIV. These require immediate IV antibiotics. Viral meningitis is the most common and less severe. It can be caused by herpes simplex, enteroviruses, or even influenza virus. It's usually self-limiting and only requires supportive treatment. Fungal meningitis is rare, but occurs more in immunocompromised individuals. Causes and risk factors of meningitis include respiratory droplets from infected individuals, bacterial or viral, direct spread from ear infections, sinusitis, or skull fractures, and sepsis. Risk factors are crowded living environments like dorms or military housing, immunocompromised state, infants and young children, older adults, and those who are not vaccinated. Signs and symptoms depend on age and type, but classic symptoms include fever, severe headache, nausea and vomiting, and nuchal rigidity. Neurological symptoms include photophobia, altered mental status, confusion, seizures. In infants, you will see poor feeding, bulging fontanelles, irritability, and lethargy. Meningococcal meningitis Q is petechial or purpuric rash, which is life-threatening. Diagnosis is a lumbar puncture is gold standard. CFS analysis will show increased white blood cells, increased protein, decreased glucose with bacterial infections, and a positive culture or PCR. Additional testing may be blood culture, CBC, electrolytes, and CT. Bacterial meningitis is an emergency. It is treated with IV broad-spectrum antibiotics, corticosteroids, IV fluids, and they are put on seizure precautions. Viral meningitis, supportive treatment of rest, fluids, and antipyretics, and antivirals for herpes meningitis. Fungal meningitis, long-term antifungal therapy is needed. Complications are brain swelling, hearing loss, seizures, hydrocephalus, septic shock, and death. Vaccines may help prevent meningococcal virus, pneumococcal vaccine, and Haemophilus influenza type B. Other preventative measures are hand hygiene, avoiding sharing drinks or utensils, and prophylactic antibiotic use for close contacts. LPN considerations are assessment for neurostatus, check vitals frequently, assess for headache, stiff neck, or photophobia, observe for rash or changes in LOC, and monitor for seizures. Interventions include maintaining droplet precautions until cleared, administering antibiotics and steroids as ordered, managing fevers, reducing stimulation, keeping patient hydrated, and monitoring INO. Patient and family education, the importance of vaccines, early signs of meningitis, infection prevention measures, when to seek emergency care, and for close contacts, follow prophylaxis instructions.